Hi, I'm Steve Zellig, founder of FitTest, and in this video, I'm going to be talking about acute coronary syndrome, made up of stable and unstable angina and non-ST elevation myocardial infarction and ST elevation myocardial infarction. So ACS, acute coronary syndrome, refers to any constellation of clinical symptoms that are compatible with acute myocardial ischemia. So acute coronary syndrome is divided into ST elevated myocardial infarctions, or STEMI, non-ST elevated myocardial infarction, or NSTEMI, and unstable angina. STEMI results from complete and prolonged occlusion of an epicardial, that is the large coronary artery, and is defined on ECG criteria as ST elevation coinciding with transmural or full wall thickness infarction and the production of many metabolites of myocardial injury, which we'll come to later. NSTEMI usually results from severe coronary artery narrowing and transient occlusion or microembolization of thrombus or atheromatous material. NSTEMI is defined by an elevation of cardiac biomarkers without ST elevation and is a subendocardial or inner wall infarction. Unstable angina refers to an unstable plaque causing transient myocardial ischemia that coincides with thrombogenesis, clot formation, interspersed with thrombolysis and clot digestion. So in other words, the person comes in and out of angina depending on what's happening to that region of unstable plaque. A differential diagnosis is needed to exclude unrelated pain. Now, separate to all that, we can also think about coronary artery vasospasm, spontaneous coronary artery dissection or SCAD, and myocarditis, endocarditis, pericarditis, and similar inflammations. For example, post-COVID. They can also be considered as acute coronary syndrome, but they're unrelated to atherosclerosis. And there are other conditions as well producing chest pain and coronary insufficiency that are unrelated to atherosclerosis, but will not be covered in this talk. The management of acute coronary syndrome should focus on rapid diagnosis, risk stratification, and institution of therapies that restore coronary blood flow and reduce myocardial ischemia. Now, these are some nice pictures of what we've just been talking about. So without stable angina appearing here, this is just unstable angina. So in unstable angina, we have an artery, maybe a smaller artery, rather than the main epicardial arteries, that come in and out of, the plaque is unstable and comes in and out of occlusion. So minimal occlusion in terms of the time or the duration of occlusion, but also maybe smaller arteries. There's no long-term damage to the myocardium, so there's no myocardial necrosis, but it does show on ECG as ST depression sometimes, T-wave inversion, but also you can have a normal ECG going with the chest pain. And the troponins, which are indicative of myocardial injury, are not elevated. In NSTEMI, there is a severe occlusion of epicardial arteries, maybe the smaller arteries, but maybe not, maybe the larger arteries. It's slightly less duration compared to STEMI, and the necrosis that follows from this, the myocardial necrosis, is subendocardial, in other words, on the inner wall of the heart muscle, as is shown quite nicely in this picture here. On ECG, there's chest pain at rest, as there is in unstable angina. There is either a normal ECG or there's T-wave inversion, and ST depression is possible as well, not ST elevation. So that's non-ST elevation myocardial infarction. And there is the production of troponins, which indicate myocardial injury. And then we come to STEMI, which is complete occlusion of an epicardial artery and prolonged to the extent where the heart muscle starts dying inside on the subendocardium and then spreads through the full wall, and we get a transmural necrosis. And as that heart attack evolves, or myocardial infarction evolves, if you have ST depression initially, that will flip eventually to ST elevation, shown in this ECG where I'm pointing now. There's chest pain at rest, as for the others. There's ST elevation, and there's a much larger production of troponins, indicating a larger location of myocardial injury. Now, we can also see on ECG, it's possible sometimes to see an old STEMI, not an NSTEMI, but an old STEMI, indicated by permanent deep Q waves, more than 25% depth compared to the height of the R wave on that particular lead. So that is fairly useful if you wanted to look at the history. If someone has a history of STEMI, then you can have a look at that. But none of these things are really needed for us as exercise professionals, because we should not be seeing any of these clients during exercise, of course. And we certainly hope that exercise itself hasn't precipitated any of these events. So these are all non-candidates for exercise. If NSTEMI is not treated urgently in the first hour of chest pain onset, then the NSTEMI may proceed to a full wall thickness infarction, or STEMI. Now, a lot of people ask me about, or try to understand, why sometimes you get ST depression and sometimes you get ST elevation. It sounds very confusing. I found this website from the National Institute of Health in the US, which I think provides a really good explanation. And I'm not going to go through all of this in detail. This slide is here for you to look at, and you can also click on the link to go into this topic in more detail. But just to simplify it as best we can, if we take ST depression as a concept first. So what happens in ST depression, which is non-transmural ischemia, that is subendocardial ischemia, where the ischemic region is, and this might be unstable angina or an NSTEMI, then we get some radiating, depolarizing currents that radiate out from the injured or the ischemic region, ischemic or injured region. And if you've got an electrode sitting very close to that, for example, here is sitting on the lower part of the heart, the apex, but pretty much towards the left free wall. So this might be V4 or V5 on a 12-lead ECG, and it's seeing these depolarization waves. Sorry, these electrical waves coming towards that electrode in the resting state. So this is the resting state. The rest of the heart, the viable heart muscle, is resting. This is the ischemic or injured region of the heart, generating these small currents, moving towards this electrode. And because they're moving towards, it causes an upward shift in the baseline, not the ST segment, the baseline. And so when you go to the depolarized, or in other words, systole for these ventricles, then the whole heart depolarizes and the current disappears, and now we have zero voltage. And then when it repolarizes back to the resting state, the same thing happens as over here in the resting state. And we've got these currents moving towards this electrode, V4, V5, causing this upward deflection of the baseline. So ST depression is not so much the depression, but an elevation of the baseline causing an apparent ST depression on ECG. So it's a little bit nuanced in the explanation, but I think that's the best way I can explain it. Now, ST elevation is pretty much, if you understand what I've just said for ST depression, then this gets a little bit easier. So in ST transmural ischemia or injury going on to STEMI, then what happens is we've got the full wall thickness involved here, and now the currents move away from this active electrode and effectively drops the baseline, so that when the heart muscle depolarizes in systole, the whole heart muscle depolarizes in systole, bringing it back to 0 volts. we have this apparent ST elevation because the baseline's been dragged down. And then it's restored again in the repolarized state when it goes to rest. So I think these are nice pictures to explain these two phenomena. Now we come to tying some of these concepts together. And first of all, stable angina, which is number one here. This is the only one of the four in which we can exercise our clients. So it's important to really understand how to deal with it, stable angina, and I'll have something more to say about that towards the end of this little talk. Now, what happens in stable angina is the angina pain develops when there's increased demand in the setting of exercise. So, for example, in exercise. Now, if we go to the Fick cardiac formula, the oxygen demand and supply, if you like, in the heart muscle depends on coronary artery blood flow, of course, multiplied by the oxygen concentration in arteries, minus the coronary artery blood flow times the oxygen concentration in coronary sinus. Forget about all this second part of the equation. What's really dependent on oxygen supply to the heart muscle is coronary artery blood flow, hemoglobin concentration, and O2 sats. They're the three components that are most important. Now, STEMI and NSTEMI and angina are all talking about coronary blood flow, not hemoglobin or O2 sats. These are different topics altogether, and these both should be normal in all of these settings here. So we're really just talking about an abnormality in coronary artery blood flow. In stable angina, the problem, at rest, there's sufficient blood flow through the coronary. There's sufficient blood flow, so there's no chest pain. When they go to exercise, we require more coronary artery blood flow. It's partially obstructed by the atherosclerotic plaque. And so that's what we mean by demand ischemia. The demand has gone up, but it hasn't been able to be supplied due to the atherosclerotic plaque. So what you get in stable angina, you can have a normal ECG at rest, or you can have ST depression, plus or minus T-wave inversion in exercise, but not at rest. And there's no elevation in troponins. Now, in unstable angina, which I've already covered, what we have here is the plaque is by definition unstable, and a thrombus can form and then be digested again, thrombolysis, so thrombogenesis, thrombolysis, coming in and out of this state as the plaque is unstable. And so at rest, there might be a period where there's no chest pain. And then they develop chest pain as a microthrombus forms. And so that obviously they cannot do exercise. This is a supply ischemia because when the plaque is most unstable, there's even insufficient coronary artery blood flow to supply sufficient oxygen, even in the resting state. So these people have a chest pain in the resting state. Again, they can have a normal ECG or ST, depression and or T-wave inversion, and these are all shown here. Now we go on to NSTEMI, which we've already covered, and this is maybe a smaller artery or more transient occlusion compared to the STEMI. So it's either the extent of occlusion, the amount of occlusion, or the duration of occlusion, which becomes important in NSTEMI. And as I said before, NSTEMI, the important thing is get to hospital, get urgent coronary artery revascularization as a treatment, and that can then restore blood flow, and that will deal with both the chronic disease and the acute coronary syndrome. So chest pain at rest, normal ECG or T-wave inversion, and plus or minus T-wave inversion plus or minus ST depression, and increase in troponins. And in STEMI, as I've already said, here's ST elevation. Here we have a prolonged and total occlusion of a larger artery, and this results in full wall thickness, transmural infarct. This one's subendocardial infarct. This one has no infarct. So it's supply ischemia. This one's demand ischemia and no infarct. And number one, stable angina, we can certainly exercise our clients. Now, just to take a stable plaque and unstable plaque a little further, one thing that statins do is they they stabilize atherosclerotic plaque, and they do it by increasing the size of the fibrous cap and making it less susceptible to intracoronary thrombogenesis, which is a good thing. So it increases, it doesn't necessarily increase the lumen size, the blood flow, but it stabilizes the plaque from that cholesterol, from the cholesterol plaque. So that's what statins do. One of the things they do, apart from lowering cholesterol itself. So if you have a thin fibrous cap, then you're more susceptible to thrombogenesis, thrombolysis, going into that unstable angina situation. Now, one of the things that we are aware of these days is the coronary artery calcium score. And these are indicative of the total load of coronary atherosclerotic plaque. And it's interesting that for those who are fit, there's a reduced risk of acute coronary syndrome when they have a high calcium score in the setting of high fitness. So high fitness won't drop in itself the calcium score, but it will make the calcium score less impactful. Now, this is just a quick picture of the main coronary arteries that can be involved: the right coronary, the left circumflex. The left circumflex and the right coronary tend to wrap around the other side, and you can see it here, and they compete for dominance in the posterior part of the heart muscle. So one of these arteries generally can be described as dominant, and you'll often see that on an echo report. So that's just showing the various arteries there. You've got the left main coronary, which bifurcates into the left circumflex and the left anterior descending, and then you've got the separate to that's the right coronaries. And these arise from the ascending aorta just above the aortic valve shown here. And this just shows the effect of STEMI in this case, so full wall infarctions. A posterior infarct will be either right coronary or circumflex, depending on the dominance of the artery. Left main is a disastrous infarction. It usually results in death, unfortunately. Not many people survive this. It has a very poor survival rate and poor prognosis. And this is occlusion of the left main coronary shown here. And it's a massive anterolateral myocardial infarction. The anteroseptal myocardial infarction comes from the left anterior descending blockage, and the left circumflex is a lateral infarction. NSTEMI, similar patterns, but the necrosis is subendocardial only, inner walls, and the outer wall remains viable. And this is the left ventricular remodeling following myocardial infarction. And this just shows a normal heart. And this is what the heart will function like prior to an infarction. Stroke volume is indicated by the annulus, that is the volume of blood from end diastolic volume, which is the unbroken line here, which I'm indicating, and end systolic volume is the dashed line here, and the volume in between is the volume of the ejected blood, which is stroke volume. And similar over here. But what happens after an infarction is you can have regions that no longer contract because of the necrosis, and they are called akinetic. You can also have regions of heart muscle that are poorly performing but still contract a little, and they're hypokinetic. And you can even have regions of heart muscle that contract inappropriately, in other words, bulge out during systole when they should be contracting inwards during systole. And we call that dyskinetic regions of the heart muscle. You can also get dilatation of the infarcted area, and even aneurysms can form, although we don't normally see that. And then you can have some compensatory hypertrophy on the remaining viable myocardium, which then contributes a little more to stroke volume in order to maintain stroke volume. So people post-MI don't necessarily have a lower stroke volume. They don't necessarily go into heart failure as defined by lower stroke volume, but they could, depending on the size of the infarct. So the treatments now, we come to that. So for stable angina, which is really the candidates that we see for exercise, is there's no urgent treatment, but the non-urgent will be CABG, coronary artery bypass graft, or percutaneous coronary interventions, PCI. That's stenting, in other words. So bypass or stent. And then the chronic treatments are the first lines of the anti-anginals. So you can be looking for either the short-acting, such as glyceryl trinitrate, which is GTN sublingual spray, for the client to self-administer. You won't be administering that, but self-administer. Or you can, happily these days, we often see clients with long-acting anti-anginals that give them 24/7 coverage if they take it according to the prescription, and that's isosorbide mononitrate, such as Imdur and Monodur. These drugs end in DUR for duration, and they're tablets. And then second line to that, so beta blockers are not given first line for anti-anginal effect, but they are anti-anginal, and I'm not going to go into it in this lecture here. Calcium channel blockers, angiotensin converting enzyme inhibitors, angiotensin receptor blockers, and antithrombogenics are all second-line drugs. In the case of the antithrombogenics, it can be aspirin, Cartier, clopidogrel, ticagrelor, oral anticoagulants, and many more. And then the prevention side of it, there are statins, and there's also other aggressive lipid-lowering therapies available. In particular, the most aggressive would be the PCSK9I. Don't ask me to spell that out. And evolocumab, I can hardly say that. Sequestering agents, cholestyramine and ezetimibe also used. So there's a wide variety of drugs that are used in stable angina. In other words, chronic coronary artery disease. Unstable angina, where now there's clinical decision-making on the part of the cardiologist as to whether they're going to undergo urgent or non-urgent, that is elective CABG or percutaneous coronary intervention, stenting. And the treatments, while they're in unstable angina, they'll probably have ongoing treatments along the lines of stable angina. NSTEMI, again, clinical decision-making around whether it's going to be treated urgently or not urgently, depending on the patency or the patency of the remaining coronary arteries and what can be done to prevent NSTEMI going to STEMI. So very often you get urgent revascularization. By the way, we call all of these treatments here urgent and non-urgent. Collectively, we call that coronary revascularization, and it can be urgent or non-urgent depending on what timing is done and what procedure is done. So the chronic treatment for NSTEMI is likely to be CABG or PCA, and that may eliminate the need for many medications, but it's very likely that long-term prevention meds, especially lipid lowering, will be needed. For STEMI, again, is it going to require urgent or non-urgent revascularization? CABG or PCA may eliminate the need for many medications, but it's very likely, again, same thing as for NSTEMI. SCAD, interestingly, they don't undergo either urgent or non-urgent PCI or CABG. And the most effective treatment, according to the latest literature on this topic, that is spontaneous coronary artery dissection, is conservative management, keeping blood pressure under control, and time for natural healing is about 6 months. Coronary artery vasospasm, again, conservative management, but calcium channel blockers are often given, possibly also beta blockers and statins, and no other treatment is needed. We now come to exercise. So in stable angina, who are candidates for us as exercise professionals, the main thing you need to try and either know from for example, a stress echocardiogram, or be able to measure yourself or identify yourself or any ischemic thresholds that may appear. So you could use a sign, symptom of fatigue, limit and incremental exercise test, and then when you go to prescribe exercise, stay a safe distance under any angina threshold. Remembering that these patients should, if they're coming along for exercise, have an anti-anginal of some kind that they're taking, and that will make the exercise test relatively safe. So as soon as you see signs or symptoms of ischemia, then you're stopping at that point, unless, of course, you're doing this in a hospital environment where there's urgent medical treatment available almost instantaneously. But in my practice, I practice outside of a hospital. I'm quite happy to get to the angina threshold so long as the person has some treatments that they either are bringing to the session or have taken as long-acting anti-anginals. So if it's short-acting anti-anginals, they must bring them. So I've just said that here. Clients must bring any short-acting anti-anginals with them for all exercise, not just the initial session, and that includes supervised and non-supervised exercise. But long-acting anti-anginals do not need to be brought to the exercise sessions. And you can also screen for any other adverse signs or symptoms such as arrhythmias, exaggerated blood pressure responses, and so on. Unstable angina, do not exercise. You're not going to see them. I never see these until treatments are instituted and completed and the person comes along having been optimally managed. Then screen for any remaining ischemic thresholds using a sign, symptom, and fatigue-limited incremental exercise test, or rely on that same information from, say, a stress echocardiogram. Also screen for any other adverse signs or symptoms, such as arrhythmias and exaggerated blood pressure responses. For NSTEMI, allow sufficient recovery from CABG or PCI as applicable, and then screen for any remaining ischemic thresholds if they weren't immediately obvious to you through, say, a post-CABG, post-PCI stress echo report. You usually don't get those, so you usually have to rely on your own ability to identify any remaining ischemic thresholds and also any remaining adverse signs or symptoms. So I strongly recommend a sign, symptom, fatigue limited incremental exercise test, or you can rely on that same information from, say, a post-CABG, post-PCI stress echo, but it's so rare that I would ever see that. So I really don't get to rely on that very much at all. And for STEMI, it's the same as for NSTEMI. SCAD, you need plenty of time for healing, and they need to have really good blood pressure control so they don't further rupture those arteries, and then proceed as for stable angina advice. Coronary artery vasospasm, monitor adverse signs or symptoms such as chest pain, severe breathlessness, early fatigue, and so on. So that's all I really wanted to say. Thanks for staying this long with the video, and please contact me at info@myfittest.com.au if you would like to, if you'd like any further help on this topic. Have a great day.